is the radiology something that we can use to add to what we know? And I think the answer is absolutely it is. But many of us, and me included, I fall into this trap. We treat the radiograph. We use the radiographic evidence as a panacea and say, well, there's radiographic change. It doesn't matter how the tooth responds to pulp testing. It doesn't matter what the clinical history is. There's a shadow at the root apex, and we should treat it. Well, from my perspective, that opens up some potential doorways for us to walk through that are going to lead to diagnostic inaccuracy and potentially inaccurate treatment. So who's reading the radiograph? The classic Goldman and Pearson study from 72 and 74, they basically found that we don't agree with ourselves and we don't agree with each other. So if we look at radiographs and several different clinicians evaluate the radiographs, we'll find that we agree with each other approximately 50% of the time as to whether or not there's a periapical radiolucency. But if we're asked to look at the same set of radiographs approximately 1 month later, we'll find that we don't even agree with ourselves, but 80% of the time. And that's true of digital imaging as well. This is Turi et al. This is Journal of Endodontics 2011. It doesn't matter if it's a old school film or if it's a digital image. The bottom line is this is a subjective piece of information. How I look at a radiograph and what I see may differ vastly from what other clinicians might see or interpret as being normal or abnormal. So as we pause for a moment, as I throw this arrow in here and we look, is that a periapical radiolucency, right? Some of us may say yes, some of us may say no, some of us may say I don't know what pulp testing is, and from my perspective, that's really the right answer for me. I want to know how that tooth responds. The response of the tooth is going to drive my decision making. It's going to make me more concerned about a pulpal etiology depending on the testing or less concerned about a pulpal etiology. But the bottom line is I'm going to use that pulp testing to drive my decision making. And when we think about the limitations of radiology, it would be a periapical radiolucency with an inflamed or viable dental pulp. And Yamazaki et al. Says, yes, there can be. And I think this is relevant as we move forward and look at a couple of cases. So tooth number 19 is very sensitive to both hot and cold. It's percussion sensitive. There's a widened ligament space by my interpretation around both the mesial and distal root ends. And when entering into this tooth, there was an extremely inflamed dental pulp. So I do believe that there can be periapical changes prior to bacteria making it to the periapical tissues based on the inflammatory response caused by the pulp inflammation. But as we look at this particular tooth, here we see a heavily restored tooth number 19 with a widened ligament space along the mesial aspect of the mesial root. And unfortunately, although this very much mimics the case that I just showed of an irreversible pulpitis, this actually represents an osteosarcoma. So here we see the first example of a non-odontogenic but very serious and life-threatening pathology in the periapical region that could potentially be misinterpreted and treated endodontically when, of course, that would be completely inappropriate. So there we see the side-by-side of the irreversible pulpitis on the left and the osteosarcoma on the right with the symmetrical widening of the periodontal ligament space at that level of the tooth. Another example of a widened periodontal ligament space in tooth number 13 associated with an irreversible pulpitis. And the testing in this case, again, doesn't lead to much uncertainty. It's very responsive with a linger to cold, and on access, there's an extremely inflamed dental pulp. Continuing with the theme of before, however, here we see a relatively unrestored tooth number 13 with another symmetrical widening of the ligament space. And as we look at those two images side by side, we see the irreversible pulpitis on the left and another example of osteosarcoma on the right. I can't tell you how that tooth would test. We could see a variety of different possibilities depending on the malignant infiltrate that's there. That tooth may not respond to a thermal stimulus, it may. I don't know the answer because that's a case from the pathology days rather than my endodontic practice. But the bottom line is this tooth would be very percussion sensitive and it would behave differently following any endodontic treatment than the typical tooth that I would treat because it would continue to be painful and problematic. So hopefully I would get the diagnosis correct on the front side, but have the understanding that if I didn't nail the diagnosis and I did treat that tooth endodontically, I wouldn't expect that it would behave in the same manner. I would expect the pain that's there preoperatively to persist postoperatively, and then it would be incumbent upon me to make a decision about why that's the case. Were my diagnostics inaccurate from the get-go? Here we see tooth number 19. Again, there's a widening of the periodontal ligament space around the mesial root. This tooth is very sensitive to both cold and heat, a lingering response to cold on pulp testing, and a very inflamed pulp on access. So some of those things are a little bit more straightforward, but yeah, I definitely believe that there can be periapical change, certainly widening of the ligament space in the absence of bacteria at the root apex, simply because of the inflammatory response. So from another perspective, as we look at the limitations of radiology, bone loss is only going to be detected, according to Bender and Seltzer, if the lesion is big enough to hit the cancellous bone. And that lesion needs to be big enough to get to the junction of the cortical and cancellous bone. It needs to impact the cortical plate. And when we look at Ron Shoha's work, this is 000 1974, lesions were always larger in the clinical finding than they were radiographically. And lesions were evident before the junction of the cortical plate. So this is in direct contrast to the previous article that I just showed. Certain teeth are more prone to exhibit radiographic changes than others, and this is definitely the case. I did a periapical surgery on a tooth number 9 today, and following reflection of the flap, the apex was fenestrated through the cortical plate of bone. Even with my limited surgical skills, I could find that root end. Of course, that's going to be significantly different than when treating a mandibular molar through a thick buccal cortical plate. So I think that's absolutely true. 7% mineral bone loss needed to produce a radiolucency, and lesions need to be a certain size. 1 to 7 millimeters didn't produce a lesion in the cancellous bone.